Hi, this is Dipti Rao from the University of New Mexico School of Medicine, Division of Hospital Medicine, and I am going to give a talk on ultrasound for paracentesis and thoracentesis. Right now we're looking at a short quiz which goes over some of the basics of ultrasound and using the ultrasound, so I'm going to let you read that for just a minute or two and then we'll go over the answers. Okay, so the first question, ultrasound is a modality utilizing A, sound waves, B, magnetic energy, or C, electrical impulses. Ultrasound utilizes sound waves. The basis for the formation of images is A, sound waves being absorbed and reflected, B, molecular rearrangement from magnets, C, small electrical impulses causing molecular rearrangement. The answer is A, sound waves being absorbed and reflected. Next question, for the purposes of accessing fluid, we want A, greater depth of view but less resolution, or B, less depth of view but more resolution. We want A, greater depth of view but less resolution. Next question, B mode/2D is the modality we should use for ultrasound guided procedures. A, true, or B, false? The answer is A, true. And next question, the probe marker should be to the right or towards the patient's head for our purposes. A, true, or B, false? The answer is A, true. So we'll go over the answers to these questions more in depth in the talk. What I should learn from this lecture, why this is important, and some ultrasound basics. Ultrasound in procedures. So there's a lot of literature that ultrasound increases patient safety for central lines. However, for thoracentesis and paracentesis, perhaps we're not as aware of the literature, and there's not as much literature for sure. So how about ultrasound in thoracentesis? So the major complication that most papers look at is pneumothorax, and the risk of complications is anywhere from up to 19 to 29%. If we look at a couple of the earlier papers by Grogan and Reptopoulos, we'll see that actually ultrasound was shown to decrease the rate of pneumothorax. The reason why I think these two articles are interesting, they were both done in the same facility. They were both done at UMass Worcester and done around the same period of time. So the paper by Grogan was a prospective randomized trial where they took patients and randomized them either to ultrasound or no ultrasound when they got their pneumothorax. And you see that when ultrasound was used, the pneumothorax rate was 0%. When it was not used, it was about 30%. Those rates seem somewhat low and somewhat high. There are several reasons why you get a pneumothorax when you have thoracentesis. So 0% really seems somewhat low. However, those are the rates that they found. The next paper, which also was done at UMass, actually was a retrospective study of approximately 350 to 400 patients who had either ultrasound or not ultrasound for their thoracentesis. And you can see the rate of pneumothorax with ultrasound was about 3%, without ultrasound was about 18%. There have been several papers since then looking at this, as well as other factors that can cause pneumothorax and other possible complications of thoracentesis. However, it was felt that there was some confounding there, and it wasn't entirely clear that ultrasound was actually one of the things that made thoracentesis safer. So in 2010, we have a meta-analysis of approximately 25 papers looking at using ultrasound in thoracentesis, and we can see the factor which was most associated with a decreased rate of pneumothorax was ultrasound. Also, a couple of other factors in thoracentesis. So there is this phenomenon of sending the patient down to radiology, having someone mark the spot, then doing the thoracentesis after they come back up to their bed. This paper in 1991 actually showed that that did not decrease the rate of pneumothorax in thoracentesis, and actually there have been other papers that have shown this. Also, if we looked at failed thoracentesis, so those thoracentesis where they tried to do a clinically oriented thoracentesis and failed to get fluid, there was a paper in 1994 that showed 58% of clinically attempted dry taps had needle insertion sites below the diaphragm. There was a paper in 2006 that showed that patients who had clinically directed thoracentesis, subsequently when ultrasound was used, up to 88% of those patients were able to have fluid obtained. And there have been several other papers, including this one from 2003, which showed that ultrasound increased the rate of accurate site selection and decreased the number of dangerous needle insertions. In summary, the complication rate for thoracentesis is fairly high, and ultrasound can decrease that rate. How about in paracentesis? So the complication rate in paracentesis is low. It's only up to about 2.7%, and numerous papers have shown this. However, where ultrasound may have a role in paracentesis is identifying small pockets of fluid. So if you're under a situation where it's difficult to tell by physical exam if the patient does or does not have fluid, ultrasound can help you detect fluid and help you detect small pockets of fluid. Also, ultrasound can actually help you to avoid attempting paracentesis in patients who do not have sufficient fluid. So this paper from 2005 actually was a randomized control trial where they attempted to use paracentesis. They randomized patients to either having ultrasound or not having ultrasound in their paracentesis. And what happened is those patients who had paracentesis and were not able to have fluid obtained actually crossed over and had ultrasound, and subsequently several of those patients were found to not have enough fluid for paracentesis. So why should we use ultrasound in thoracentesis and paracentesis? So patient safety is a factor. We've just looked at some evidence behind that. Patient comfort is a factor. So you can have increased success in either performing your procedure or saying appropriately that there's not enough fluid to perform the procedure. The patient can remain in their room for the procedure and also have physicians who know them performing the procedure. Also, the reasons to do this: resident learning and comfort. So there's several studies that show residents don't feel comfortable performing procedures when they leave residency, and so using ultrasound may increase their comfort and also increase the number of procedures they're able to do and learn. Also, ultrasound can form the basis for a simulation-based procedural training, and there are some billing and coding aspects to it. Let's talk now about some ultrasound basics. So ultrasound basically consists of the machine and then the probe. So what happens is the probe contains crystals set in a line along its lengthwise axis. And those crystals, when doing ultrasound, actually have electricity applied to them. They then expand and contract, forming sound waves, which then are absorbed into the body. Those sound waves are transmitted and then either absorbed/attenuated or reflected, and then the machine actually interprets the returning echoes. So basically, the probe is not only sending sound waves, but then listening for those sound waves to come back. And for the majority of the time, actually, the machine and the probe are in the listening mode, trying to see when those signals come back, how long it takes them to come back, and what strength they come back with. And utilizing all that, the machine then turns those sound waves into a picture. So a couple of things to know: absorption occurs well in fat and fluid, and so those things tend to look black. Reflection occurs at the boundary between two tissues and causes bright lines or spots. So something like air actually is virtually impenetrable to sound waves, and so you'll get bright spots there. Also, the boundary between, let's say, fluid and tissue can actually cause bright spots. So the probe contacts the body via water-based gel, and again, it contains a large number of transmitters, which are actually crystals set in a line along its length. The crystals then fire simultaneously, then wait to receive the signal, record the intensity of the sound, and then that's taken back to the machine and forms the picture that you see. So the transmitters are set in a line and form a linear wavefront moving perpendicularly away from the transducer face. So this shows basically a probe. You can see the red dashes are basically the transmitters, and the yellow dashes are the sound waves moving in a perpendicular fashion away from the probe. Those sound waves then are absorbed into the body, and depending on what they hit, they're either transmitted, absorbed, or they're reflected back. And based on how far they go, how long it takes them to come back, and the intensity of the sound, a picture is formed. So you can see here we've got a probe. Just one of the transmitters has sent out a sound wave. It's hitting the circle. In the spots where it hits the circle, the sound waves are then reflected back. And based on how long it takes the sound waves to come back and the intensity with which they come back, an image is formed on the screen. If we go to the next transmitter, you can see there's only two spots where actually sound waves would be transmitted or reflected back. In the middle, let's say that's fluid, that actually just transmitted the sound waves without actually reflecting, and so you have a black area in between those two dots, and so on. So basically we have a demonstration issue. At the top of the picture where the blue dot is where your probe is placed. One end of the probe is oriented towards the head, the other end is oriented towards the feet. And we can see there's a big black area right under where the probe is. That is actually fluid. Fluid actually transmits sound waves very well without reflecting much. Once the sound waves hit tissue, what's labeled as lung, you start to see bright spots. Those bright spots actually are air in the lung. And then also towards the caudal end of the image, you can see the liver. The bright line between the fluid and the liver is actually the diaphragm. So again, just to reiterate, the transmitters set in a line form a linear wavefront moving perpendicularly away from the transducer face. The reason why this is important, it also forms the basis of short-axis imaging and long-axis imaging. So short-axis imaging is a cross-section due to the probe held at right angles to the target structure. Versus long-axis imaging, the probe and the target are aligned, producing an image in its longitudinal axis. So here we have a basic echo image. If you think about the body, the probe is actually oriented towards the head and towards the feet. And so we're getting a longitudinal or long axis image of the heart here. Now, if you take the same probe at the same exact position and turn it 90 degrees, so it's oriented towards basically towards each axillary line, let's say, you get a short axis image in the same area. So basically the ultrasound probe is taking a slice through that area of the body along its longitudinal axis. Also, the other thing to know about ultrasound physics, depending on the frequency of the sound waves, that tells you if you're getting penetration and or resolution. So a high frequency probe, basically a high frequency sound wave has a shorter wavelength. A shorter wavelength penetrates the body less well. However, you have better resolution of the target structure. Versus a low frequency sound wave has a longer wavelength but penetrates better, but the resolution of the target structure is less. So basically what needs to happen is based on the application or what you're trying to do, you need to decide, do I want a lower frequency probe, meaning I want more depth and less resolution, or do I want a high frequency probe, meaning less depth but higher resolution? So which probe would we choose for procedures? For procedures, actually, choosing the probe depends on the resolution and depth necessary. So for our purposes, we can sacrifice some of the resolution to see fluid and the surrounding structures, and we don't really need that much resolution. What we're looking for is a large pocket of fluid we can put a needle into, and we don't need a lot of resolution. We're trying to just see large structures like the lung or the liver or the bowels that we don't want the needle to actually penetrate. So therefore we want a lower frequency probe. So we use the 3 to 5 megahertz probe. Just a few vocabulary terms. So the modes, so B mode or brightness mode is the structural 2D image, which is what we've been talking about here, and that's what we want to use for our procedures. M mode or motion mode shows one line of B mode displayed over a time axis, so this is not what we want to use. Terminology. So anechoic means there's an absence of returning sound waves. That looks black on the screen. Typically fluid is anechoic unless it's got a lot of proteinaceous material in it. Hypoechoic shows very few echoes. It's darker than surrounding structures. So I'd say fluid that actually has a lot of turbulent material or proteinaceous material might be described as hypoechoic. Hyperechoic or echogenic is brighter than surrounding structures, so definitely the diaphragm might be described as hyperechoic. Also the planes. So basically we can see here, sagittal plane goes from front to back, transverse plane, actually you're taking a cross section parallel to the floor, and then coronal plane basically goes from side to side. Let's talk a little bit about the probes. So the probe basics, each probe has an indicator on it. If you can't find the indicator, basically once you have the machine set up, you can touch one side of the probe with some gel on it and you can actually see which side of the probe you are touching. By convention, the indicator goes towards the head for longitudinal views or towards the patient's right for transverse views. The probe indicator actually corresponds to a blue dot which is located on the actual image that you will see. And so what you want to do is you want the probe oriented so the head is typically towards the right of the screen or the right side of the body is typically towards the right side of the screen. And this is why the probe indicator has to be oriented in this way. The controls that you need to know for finding fluid are the on-off switch, how to select and change probes, looking at the presets and making sure that you are on the proper presets. Usually we use abdominal mode to look for fluid. You want to know how to freeze the frame. You may want to know how to measure the distance to the fluid and the amount of fluid. Changing the gain sometimes is helpful if you're having trouble seeing structures or having trouble seeing the fluid. And then the depth actually is important. Typically when I start looking for fluid, I will set the depth relatively high, perhaps even 12 centimeters. And once I've actually seen that it's not, the abdominal wall or the chest wall is not very thick and the fluid is actually not going to be difficult to access, I will decrease the depth in order to get better resolution. Also, increased depth slows the frame rate.